Oh shoot, what's it? I am so late for work. Oh shoot, I left my stethoscope at home. Doesn't matter. And my laryngoscope. Oh, and worst of all, my hat. All right, now I can go to work. Let's get busy. What's going on here? Breach? Failure to progress? Don't worry, I can fix this. Congratulations.
Thanks, doctor.
You're welcome. G'day, mate. I understand you're from Australia?
Yes.
Have you stuck something up your rectum?
Yeah, put something on my rectum.
Yeah, well, it's common amongst Australians, I understand. Nobody can get it out, is that right?
Yeah, it's stuck up there.
All right, well, I'm just going to take a little look here.
Oh,
This might hurt a bit.
Oh, no!
Is that it?
Yeah, that's it, mate.
Thought so.
Thanks.
Oh, mate. Looks like an aspirated foreign body, but I think I can get that for you if I just move in here. Holy hell, dude. Jeez. Well, drink up, son. Dudes, tough shift. I need a drink. Nice. Delicious. Good shift, huh? Saw some good stuff. All right, I gotta get home though. All right, guys, I'm out of here. What? Oh, it was just a dream.
For the next session, I want to introduce to you a legend. You know him from the MCrypt podcast. You know from MRAP, Scott Weingart. And the featured musical guest in this session is appropriately called Judgment Day. All right? So let's take a look at this video as we intro Scott in his session.
All right, resuscitation and critical care, saving lives. This is what we were meant to do as emergency physicians. Each year during this session, I bring you some of the best minds in resuscitation and critical care. And Joe and Zach, come on up here. And these are the two folks I brought this year. We have Zach Shiner and Joe Bolesso, both from Sharp in San Diego. These two gentlemen ruined my life. What happened is they decided they could push the boundaries of our specialty and bring ECMO, cardiac bypass, to the emergency department, done and initiated by emergency physicians. I had Joe on the phone, spoke with him on the podcast, and he told me what he was doing, and I said to my wife, I can't let this fucker be able to do this, and this fucker too, and not me. And so I had to quit my job, do another fellowship, simply to be near, not at, but near as worthy as these gentlemen are for what they've done for our specialty. You're gonna hear from the two of them momentarily. Guys, go sit down for now. I'm gonna bring them up to talk about all sorts of crazy resus stuff. But before we get there, let's talk about delayed sequence intubation. Every time you pick up a laryngoscope, you're being given a license to kill. And what you choose to do with that license depends on how much you care about your patients. Essentially, in our hands, the laryngoscope can be a murder weapon. Now, I've devoted a lot of my career to coming up with ways to prevent that, to prevent peri-intubation deaths, to prevent us from being the cause of a patient going into cardiac arrest in the peri-intubation. Concepts I talked about yesterday and this morning, like CPAP pre-oxygenation, apneic oxygenation, ventilator as a better version of the BVM. We're not going to talk about those today. We're only going to talk about one, DSI, delayed sequence intubation. And to talk about that, I always want to give you a case. So this case is a 43-year-old male. He's saturating 81% on a non-rebreather, high flow O2. He's got rales up to the clavicles, severe respiratory distress. But he keeps ripping off the non-rebreather mask. He keeps trying to get out of bed. He keeps shouting, "I can't breathe." And everything you do to restrain him is not working. He is pounding away with his fists at your head. Now, what would be the oral board answer on what to do with this patient? Shout it out. RSI, absolutely. And if you say that, you're going to get a full score on the oral boards. You got to take control. You got to induce them. You got to give them muscle relaxation and hope that you can get their SATs up during the peri-intubation. So what do you do when they have low SAT and the patient won't tolerate a mask? Well, obviously, you RSI them. And that's what I always used to do. Now, the problem with that is if they're already satting 80%, to go to what is the critical desaturation point, the point in which the patient gets dysrhythmia and bradyasystolic arrest, is 70%. And to go from 80 to 70 on the oxyhemoglobin dissociation curve, blink of an eye, 3 seconds, and they go from 80 to 70, and then 70 to 50, and then you are doing compressions on your peri-intubation patient. And I hated that. I hated that feeling of loss of control. ED critical care is about always being in control of your patient's physiology. And I figured there had to be a better way. I didn't want to be gambling with my patients' lives. So, how do you take back control in these patients? DSI, delayed sequence intubation. Now, to understand DSI, you got to remember RSI, and we all know this. This is our bread and butter. RSI is you give an induction agent, take away the patient's respiratory drive, put them down deep. You give a muscle relaxant to paralyze them to get full muscle relaxation, and then you don't provide a single positive pressure breath until after you have the tube in, unless the patient forces you to do so. That's RSI. That's our standard airway management. DSI breaks the sequence between induction and muscle relaxation to allow you to do some things that you want to do. Things like denitrogenating, things like pre-oxygenating, things like perfectly positioning that patient that won't sit still in the bed, gastric emptying in that patient with an enormous GI bleed and a belly full of blood. It'd be really nice to get that out. And things like briefing your team, not feeling out of control, talking about what you're going to do, talking about your difficult airway plan so that you actually feel calm and collected when you first stick that laryngoscope in. So DSI gives you that time to do those things. How does this actually work? So you have a delirious patient. They could be delirious from their disease. They could be delirious from hypoxemia, from hypercapnia. But for whatever reason, they're not letting you do what you want to do. You dissociate them. You give them an agent that will take away their fight and yet leave them breathing and leave them with airway reflexes. And the prototypical agent for that is my favorite medication in the world, ketamine. I love it. I just love this med. And I had an extensive experience with adult ketamine sedation, which is what brought this idea to me. You could give a patient a dissociating dose of ketamine, and they'll keep on breathing and keep on maintaining airway reflexes. Now, we start low because ketamine is a first-pass drug, meaning if you give it, you will see the full results, one circulatory time to the brain within seconds. So there's no reason to dose high. Some of the complications of ketamine, like hypersalivation, like hyperadrenergic vital signs, are from overdosing. So there's no reason to. Give 1 milligram per kilogram, 1 milligram per kilogram of ketamine, wait 5 seconds. If they stop fighting, if they lie back in bed, they are just chilling out now, their eyes are goggling back and forth, you're done. If they're still moving around, if they're moaning, if they're fighting you, give them another 0.5 milligrams per kilogram. Wait a few seconds. Give them another 0.5. Keep doing it until they're dissociated and they chill. There is no ceiling dose. If you do it this way, you cannot overdose on the ketamine. So keep giving 0.5 until they chill. Once they chill, do anything you need to do. Put on a nasal cannula at 15, put on a non-rebreather mask at 15 liters per minute. If that gets their SATs up, great. If it doesn't, take off the non-rebreather, put them on some form of CPAP with the nasal cannula underneath. But do enough to get their SATs greater than 95%. Denitrogenate them for 3 minutes. Wash out that functional residual capacity, that bag of oxygen that's going to give you time. And only then push your succinylcholine or rocuronium. Do apneic oxygenation during those 45 to 60 seconds and then intubate safely, with control, with calm, with no epi surging through your system. All right, we could use it for other reasons than just pre-oxygenation. I told you about that cirrhotic. Have you ever tried to put an NG tube in on a GI bleeder who you want to intubate? they don't like that so much. If you push the ketamine, all of a sudden they have incredible degrees of analgesia, they're dissociated, and you can put the NG in, suck out that, 2 quarts of blood out of their belly, and only then, when now they're a safer intubation, paralyze them and intubate. All right, DSI is not CPAP pre-oxygenation. The two work together very nicely, but when I first put this out, people conflated the two. You absolutely can do DSI simply to put on a non-rebreather mask that the patient wouldn't otherwise tolerate. All right, so all these things work together nicely. All right, where's the evidence? It sounds good in theory, and for years we've been talking about this in social media. In fact, I presented it at an Essentials 3 years ago. But we didn't have evidence. We had to extrapolate evidence. We have evidence now. This study was just published 2 weeks ago in the Annals of Emergency Medicine, and it was our first 62 patients who we did DSI on as a prospective trial, 3 centers, 62 patients. And the reasons they were getting intubated are the reasons we all intubate patients in the ED, things like pneumonia, pulmonary edema, anaphylaxis. And the actual respiratory failure, most of them, all but 2, were oxygenation failure. And then some of the patients, their oxygenation and ventilation was okay. We didn't trust their airway. They were obtunded, altered mental status, and they were getting intubated purely for airway protection. The reason they needed DSI is 31% of the patients would not tolerate a non-rebreather. Their SATs were okay, but they wouldn't let us denitrogenate them. 63% of the patients, they wouldn't tolerate the CPAP they needed in order to get their SATs up. They might have been okay with a non-rebreather, but their SATs were in the 80s. That's not good enough. We wanted to get them on CPAP. They wouldn't tolerate it. It's uncomfortable. And then for 6% of the patients, we wanted that NG tube in to actually allow gastric emptying. Now, David Schreiger, who you heard from this morning, made this beautiful diagram for me for the Annals paper. And once you understand how these parallel line graphs work, it would make complete sense. But I don't have the time to explain it to you. So this is a lot easier. On the left side of the screen, you have the pre-DSI saturations. On the right side of the screen, you have the post-DSI saturations. And you can see the pre-DSI, we tried our best attempts to beg this patient to keep on the mask, to stay in bed, to stop fighting us. And that's the highest SAT we could get. On the right side of the screen, that's where they were after we pushed the ketamine, after we pre-oxygenated them properly, right before we pushed the muscle relaxant. And you can see in all but 2 patients, we had an increase, or they stayed the same and allowed denitrogenation. 2 of the patients decreased the tiniest bit, 2%. Both of those patients decreased their SATs. So not significant. But that's not what I really care about. These weren't the ones where I thought we really had the win. These patients were the ones whose pre-DSI saturation was less than equal to 93%. Dan Davis in San Diego taught us that these patients are the critical desaturators. These are the ones who have a marked drop in their saturations during the intubation. These are the ones that die on you during the intubation. These patients, the ones that started off less or than or equal to 93%, every single one of these patients improved their saturation with DSI, and all but 2 of them came above that threshold of 93. These are the patients you potentially could save a life and not have a peri-intubation cardiac arrest. There were no complications. 2 patients actually avoided intubation. That's the dirty little secret of DSIs. You take that asthmatic, they look like crap. They won't tolerate nebs. They won't tolerate non-invasive. You give them a little ketamine, all of a sudden they're chilling in bed. You put them on the non-invasive, you put nebs through it, and they look so sweet, so peaceful that you decide to let them wake up. And a lot of the times when you do, they look beautiful and you don't need to intubate them. If they wake up and still are in distress, you can now intubate them because they had 20 minutes of pre-oxygenation. I don't recommend doing this. We did it in the study, but it's not ready for prime time yet. I would say if you do DSI, just tube them. All right, want more evidence? Well, then you have to extrapolate a little bit. But when you look at adult ketamine sedation, adult, I know nothing about peds, Andy, so I can't help you there. But in adults, the complication rate is virtually nil for the things we care about. What is the major complication of ketamine? Yeah, exactly. They go crazy when they wake up. I don't care about that. These guys, they're not waking up. They're getting intubated. So that's not a problem. All the rest of it, laryngospasm, case reportable. 1 case report of adult laryngospasm. Prolonged apnea, not been a single case report. If you push ketamine fast, patients will stop breathing for between 10 and 15 seconds, and they always start breathing again. So either push it slowly or just don't care about the 10 seconds of apnea. But there's no prolonged apnea from ketamine. There is no laryngospasm. There is no peri-intubation or peri-procedural emesis. A lot of them puke when they wake up. They won't puke while you're pre-oxygenating them. So if you extrapolate from the adult ketamine literature, and my friend Ruben Strayer gathered it all together, remarkably safe. What if you were the first case of adult prolonged apnea from ketamine? Well, you don't push the ketamine, walk away, see a few chest pain patients, come back, check in. Oh, yeah, he's doing okay. And no. If you're going to do DSI, you have all your intubation equipment, all your difficult intubation equipment, all of your meds for the intubation, all of your meds for post-sedation, everything you need at the bedside, and then you push the ketamine and you sit there and you watch the patient. And if they were to have apnea, you were that first case ever, then just push your muscle relaxation and intubate them, and it's exactly as if you RSI'd that patient. All right, we already said emesis doesn't happen during the procedure. Can you put a patient on CPAP with altered mental status? Hopefully our study says you can if it's ketamine altered mental status. They are preserving their own respiratory rate and they are preserving airway reflexes. All right, what if the patient's hypersensitive or tachycardic? Well, ketamine doesn't feel like the best choice. We've done it. We've gotten away with it. We've given little things like a little bit of fentanyl, maybe a little midazolam to temper the vital signs, but I don't recommend it. We're looking at other agents. Now, people ask, can those other agents be propofol? Etomidate. We have a lot of familiarity with procedural sedation with these meds, and I would say at this stage of the game, no. Not because you're not the best procedural sedators in healthy adults with a hip or a shoulder out, but because in the critically ill, the doses change. And I don't know the dose of propofol in a critically ill patient that will keep them breathing but chill them out. I don't know that dose of etomidate. So those aren't the meds we're looking at. We're looking at this medication. Very expensive right now. It'll be generic this year, and it may have some role. FDA approved to sedate patients for non-invasive. So it seems made for DSI. Unfortunately, you can't push it. You have to drip it in, so it's not ideal. This medication was my great hope, and then it stopped being manufactured. If it comes back again, this may be the answer. Droperidol will absolutely keep a patient breathing, but will chill them out and allow you to do what you need to do. If this agent does come back and we start getting a little bit more experience with it, you will have to give another induction agent with your muscle relaxant because this will chill them out, but it will not put them out. They still have awareness. But we're looking into this, not ready for prime time yet. All right, to bring it all home, DSI is just procedural sedation, and the procedure is pre-oxygenation. And as ED docs, we're damn good at procedural sedation. We can do this. Every time you pick up a laryngoscope, you are being given a license to kill. And how you go about using it depends on how much you care about your patients. This is the most vulnerable moment in the patient's hospital course. Their lives are in your hands. Please do not let the laryngoscope be a murder weapon. And with that, I thank you for your attention.